60,000 severely affected babies are born every year with this disease, and each looks perfectly healthy at birth, then crashes into profound anemia at 6 to 12 months, exactly as fetal hemoglobin fades. This is beta-thalassemia. Adult hemoglobin is a balanced tetramer. 2 alpha chains locked to 2 beta chains. Here the alpha pool on the left and the beta pool on the right pair up 1-to-1 inside a developing red cell precursor. The ratio is 1. Now a mutation strikes the HBB gene on chromosome 11. Beta plus mutations cut beta output. Beta 0 mutations abolish it entirely. The beta chains stop arriving, but the alpha factory keeps running at full pace. This is the heart of the disease. It is driven less by the missing beta chains than by the excess unpaired alpha chains. With no beta partners, free alpha piles up and the alpha to beta ratio climbs from 1 toward 4. Alpha chains are insoluble on their own. They precipitate as inclusion bodies against the cell membrane, generating oxidative damage and membrane injury inside the developing red cell. So the precursors die in the marrow before they ever mature. Ineffective erythropoiesis. The marrow expands massively to compensate, crowding bone into chipmunk faces and a hair-on-end skull, yet delivers few functional red cells. The diagnosis is made on hemoglobin electrophoresis. Excess delta chains pair with alpha to form more HbA2, which rises above 3.5%, the threshold for beta-thalassemia trait. Fetal hemoglobin, HbF, climbs too. Meanwhile, ineffective erythropoiesis suppresses hepcidin, so the gut hyperabsorbs iron, compounded by transfusion. Iron overload cardiomyopathy is the leading cause of death, which is why cardiac T2-star MRI and chelation are central. Therapy attacks each step. Transfusion suppresses the sick marrow, oral chelators like deferasox strip iron, and luspatercept, an activin receptor ligand trap, promotes late erythroid maturation so more cells survive to leave the marrow. Here's the do not miss trap. Thalassemia trait mimics iron deficiency. Both are microcytic, but trait has a high normal red cell count, a Menser index under 13, normal ferritin, and elevated HbA2. Give iron to a thalassemia carrier and you help nothing while risking overload. Why?